Welcome to our very special webinar about laser ablation for pediatric drug-resistant epilepsy. I'm Monica Jones. I'm the visionary founder and executive director of the Pediatric Epilepsy Surgery Alliance, formerly known as the Brain Recovery Project. We're the only nonprofit organization that's solely dedicated to the community of children with drug-resistant seizures who need some type of neurosurgery to treat that epilepsy. Dr. Raskin joins us today. He's an attending physician in neurosurgery at the Ann and Robert H. Lurie Children's Hospital. Welcome, Dr. Raskin.
Thank you so much. It's a privilege to be here. I appreciate the invitation.
Thank you. Now, let me see here. Oh, Audrey, are you controlling the slides? Yeah. Oh, let's go back. Thanks, Audrey. Before we get started, I just wanted to briefly go over the three types of treatments for epilepsy. The first is medication that we're all familiar with. And the second is surgical treatment, which we discuss with our families, which we serve our community to help them understand those treatments. And then the third is dietary. Next slide. A referral for a surgical evaluation should be offered to every patient with drug-resistant epilepsy up to about 70 years of age. So that includes children. And this should be done as soon as drug resistance is established. No matter how long the epilepsy has lasted beforehand, no matter the sex of the child, their socioeconomic status, their seizure type or their epilepsy type, or where those seizures are located, and most importantly, what their comorbidities are. So if you have a child with an intellectual disability, with other comorbidities, other things that are happening to them, the International League Against Epilepsy, which is the large international body that really starts to set these standards for us, has said that those children should be referred for an epilepsy surgery evaluation as soon as they're drug resistant. Next slide. When is epilepsy drug resistant? It's after failure of 2 tolerated and appropriately chosen epilepsy medications. 2. It's a very low number. If you go to our YouTube channel, you'll see an extensive video or on our website about how you meet that 2 failed medication standard. So we won't really talk about them here, other than to say that if your child has failed 2 medications, it's time to ask for a referral for a surgical evaluation. Next slide. Dr. Raskin, will you first tell us a little bit about yourself, where you studied, and then let's talk about surgical evaluation.
Sure, Monica. Thank you so much. I think that was a great introduction, and I'm excited to talk about this because laser ablation is one of my favorite topics. I went to residency at Oregon Health and Science University in Portland, Oregon. That's a 7-year training program. And then I did a 1-year fellowship at Texas Children's Hospital, which is one of the busiest epilepsy treating programs in the nation and probably the world. It is where I met Dan Curry, my advisor and trusted mentor, who was the first person ever to apply laser ablation to patients with epilepsy syndromes. And then from that, of course, it has really exploded. After fellowship in 2017, I went to Indianapolis, Indiana at Riley Hospital for Children and was an attending surgeon there for 5 years, where we built the 4th largest pediatric ablation program in the nation. And then I went on and very recently, only about 1.5 years ago, to work here at Lurie Children's Hospital in downtown Chicago.
That's great. Well, we're really honored you'll join us.
Can
you talk a little bit about comprehensive surgical evaluation, at least the first phase? We like to tell families having a surgical evaluation doesn't mean you've decided your child will have surgery. You've just decided to understand all of your options so that you can make an informed health decision for your child.
Yeah, that's absolutely correct. It is in no way binding. It is informational only. We separate the surgical management of epilepsy into 4 phases: phase 1, 2, 3, 4. Phase 1 is the non-invasive or pre-surgical evaluation and is really defined by 5 things. Number one is a history and physical exam, where we understand the semiology, or what a seizure looks like. Number two is a video EEG, where you see EEG on the left there, and that's an EEG where a patient is inpatient, and there is also a video associated with it, so we can understand how seizures start. Then there is neuropsychological evaluation, which is not on this slide, but is a very key component to understand how a patient functions cognitively and emotionally. And then there are two more things. One is structural imaging, which you see there, MRI. That is really the standard of care, is a 3 Tesla MRI of the brain. And then the second thing is functional imaging. Now, functional imaging can't be legislated because a lot of different programs have different resources. But you do have to have an understanding that's additional to the structural imaging, as far as how is the brain functioning from a metabolic perspective or from a magnetic perspective, et cetera. And so what you see there are the last 3 types of functional imaging: SPECT, PET, and a patient may get all 3 of those, they may get 1 of those. But for the pre-surgical workup, you have to have history and physical, video EEG, structural and functional imaging, and a neuropsychological evaluation.
Great. So some facilities don't have some of these, like, for example, we know all facilities don't have MEG. So you're going to get a different kind of evaluation depending on the facility you go to, the hospital.
That's right.
Okay.
Next slide. So epilepsy surgery, and we'll prove this, is not a last resort. And I always tell families that no brain is better than bad brain. And what I mean by that is bad brain that causes seizures is extremely disruptive to the normal functioning of the brain. And it disallows or prevents the development of normal behaviors.
Especially in really young children, right? Babies and infants, it can really mess with how the brain lays down its networks for learning and things like that.
Yeah, that's correct. They're at increased risk, and treating children very young takes advantage of the neuroplasticity that exists in very young brains.
Yeah. Okay.
Next slide. So just to cut to the chase, there is a survival benefit to brain surgery for epilepsy. That's an important thing to hear because it's true and it's not really talked about. This is a very important recent study produced by my boss and division chief here, Sandy Lamb, and her team, who looked at thousands of children in a pediatric sort of registry hospital system, where there were about 10,000 patients treated with medication alone, about 5,000 patients treated with medication plus the placement of a vagus nerve stimulator, and about 3,000 patients who were treated with medications and also cranial surgery for epilepsy. And you see the survival rates there. Over the long term, 98% survival in patients who who had medications plus cranial surgery versus 89% of patients treated with medication alone. And if you compare the groups, you see that with the addition of cranial surgery for epilepsy, there's an 83% chance of improved survival or less chance of dying versus patients who were treated with medication plus vagus nerve stimulation compared to medication alone, a decreased chance of dying of 35%. So this is a very important thing to understand, that not only is it better to not have seizures, just anecdotally, but that there is a survival benefit.
Your chances of your child surviving 10 years out are much better after some type of cranial brain surgery. These are really powerful numbers.
Really powerful. And also the message is that brain surgery, modern day brain surgery, is not dangerous. It is not as dangerous as people think it is. And this paper hopefully will try to get at the idea that people are very anxious to see a neurosurgeon. They're very anxious and scared about brain surgery. But if you look at the data, you're much more likely to survive if you have brain surgery versus not in the setting of medically refractory epilepsy.
Yeah. Okay. Next slide. So
when I talk to families about the surgical management of epilepsy, I think it's rather straightforward to understand that there are 4 basic umbrellas. These are the 4 basic umbrellas that all of our neurosurgical procedures can fit under. Remove tissue that's causing seizures, destroy or ablate tissue that's causing seizures, disconnect tissue that's causing seizures, or stimulate it by implanting different combinations of batteries and electrodes in order to what we call modulate that activity. Next slide. What we're going to talk about today is destroying or ablating tissue using lasers, and also using lasers to disconnect tissue. We're not going to talk about removing tissue at all, and we're not going to talk about neurostimulation or neuromodulation. So what is laser ablation? Ablation just means to destroy tissue. And laser, of course, is the modality we use or the way we do it. Lasers use light. That light is absorbed by tissue to create heat. That heat destroys tissue, little small areas of the brain. It is a, quote, minimally invasive surgery because the surgical corridor, the way in which we get to the tissue that we want to destroy, is through a very small hole. In fact, it's 3.2 millimeters, which is smaller than your pinky nail. The laser probe
like a
itself,
pencil, right?
yeah,
like the size of a pencil.
like the size of a pencil. The laser probe itself that passes through the brain is 1.65 millimeters, which is extremely small. It doesn't require the removal of a piece of skull. So what laser ablation does is provide a similar volume of ablation or resection, in some cases to open removal, but without the sweeping scalp incisions and removal of bone called craniotomies. So in that way, it's less invasive. It is not experimental. It has its own CPT codes now, so even insurance companies recognize that this is not experimental. In fact, it received its FDA approval in 2007, and then subsequently another company in 2009. So we've had data now for 14 years at a minimum. And as I mentioned before, the application of laser ablation to patients with epilepsy was pioneered by my boss and mentor, Dan Curry at Texas Children's, but now has spread out worldwide and is used with good efficacy, good effect.
And you were trained by Dr. Curry, right? At Texas Children's?
I did have the privilege of training with Dan Curry. That's right.
Oh, that's great. That's great.
Okay, next slide. So as we talked about, there's a pre-surgical testing always. Patients very, very rarely proceed from just being seen in clinic to surgery without having the added benefit of a huge group and team of people, including all sorts of important epileptologists, technicians, neuropsychologists, and radiologists. Patients must have the ability to get an MRI scan. When we do laser ablation, we actually do it in an MRI scanner. And so patients are asleep during that time, but they have to not have any implants that would prevent us from getting an MRI. So that's a real critical part of the pre-surgical testing and also laser ablation itself. And then MRI should, with an asterisk, show small area of brain that is causing the seizures. The reason the asterisk is there is because it's somewhat controversial to say that a patient must have lesional epilepsy to have laser ablation. That's not always true, but it is certainly beneficial for targeting purposes, and we know that the results are better if a patient does have a lesion that we're going after. And then, as always, when we talk about epilepsy treatment or the surgical management of epilepsy, it is better if all of the data that we get in the pre-surgical testing agrees as to where the seizures are coming from. So if the EEG and the PET and the MEG and the MRI all say that seizures are coming from one place, then we can probably just address that place. If there is some confusion or it's not totally clear, we may progress to something called a SEEG, stereo electroencephalography. This is a big word which just means placement of electrodes inside the brain.
Great, thank you.
Okay, so I'm going to ask her.
Where can you have laser ablation?
Can somebody,
have-
can't see who's talking right now? I thought I had everybody on mute. If you could please mute yourselves, we're getting some feedback from somebody. Thank you.
Yeah,
Great,
thank
go
you.
ahead.
No problem. Okay, where can you have laser ablation? Okay, anywhere in the human body. Laser ablation is not just for neurosurgeons. In fact, it's used a lot by liver surgeons and hepatologists. It's used by oncologists to treat different lesions, for example, in the prostate. We as neurosurgeons use it in the spine, in the spinal cord, and also in the brain, and most commonly, of course, in the brain. But it is safe to use, and it is indicated for use in all areas of the central nervous system. We use it in the hypothalamus, and I'll talk about that, I guess, basically at the end. The hypothalamus in that left picture is the part that looks like a head with two lips. And it's basically very deep inside the brain. It's a very critical area of the brain and coordinates and accomplishes a lot of very basic autonomic functions. On the right, you see the labeling of a colored human brain with the different four lobes, and we see the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. There are often lesions throughout all of those lobes, and we can treat with laser ablation anywhere in that area of the brain.
Great, thank you.
Okay, next slide. What you see here is a gross representation of the human brain. I say gross not because it's disgusting, but because it is a gross specimen of the human brain, with some of the top portion of the frontal and parietal lobes removed. And then you can see the corpus callosum. The corpus callosum is a group of basically cables or white matter that connects the two hemispheres of the brain. It represents about 300 million cables that connect the two cerebral hemispheres. And in the middle, you see a radiographic representation. This is called DTI, diffusion tensor imaging. And this is a radiographic understanding of all of those connections that you can see with your eyes in the gross specimen. And then on the right, you see a 3D reconstruction of those cables that connect the two parts of the human brain. So we can use, go back one slide. I wanted to just highlight here that we can use laser ablation in order to disconnect the two cerebral hemispheres. And I'll show this again later in the slide. But lasers can be used, as we discussed, to destroy a small discrete area of brain. And it can also be used to disconnect areas of brain, including the two cerebral hemispheres. Okay, next slide. So what can be ablated? These are all a lot of big words, and they are all, I guess, lesions that cause seizures: cortical dysplasia, hypothalamic hamartoma, mesotemporal sclerosis, brain tumors, cavernous malformations, tubers, encephalomalacia, which is stroke, and then white matter fibers we talked about is disconnection surgery, and then non-lesional focus, brain abnormalities that do not show up on an MRI. This is the area that's somewhat controversial, but it's certainly done. I've done it before with extremely good efficacy. So basically just reiterating that anything in the human brain can be destroyed with a laser.
A lot of our families get told, you know, they have the video EEG and then they have an MRI and they're told, oh, we're not a surgical candidate. There's nothing on the MRI. Can you just for a moment talk a little bit about reliability of MRI and about really asking for the rest of the stuff you talked about during phase one, which is the other type of testing that might show up as an abnormality in the brain?
Absolutely. Yeah, there is an educational disconnect between people who do not study and participate in the treatment of epilepsy and those who do. And there's also a fast-paced technological curve that is occurring. I mean, over the last 10 years, we've seen the approval of multiple different neurostimulators and so on and so forth. The application of MR thermography and laser ablation, all this stuff has come on in the last 10 to 15 years. So people who have not necessarily been keeping up on that, their individual opinion may be that you're not a surgical candidate. But the reality is every patient who has medically refractory epilepsy after 2 medications that are appropriately chosen and adequately trialed, which is what you stated in the very beginning, deserves a surgical evaluation. And it is up to a group of epileptologists and neurosurgeons and neuropsychologists and neuroradiologists, everybody's whose sole job is to study this diagnosis to give you that opinion. And so if you have received an opinion based on an MRI scan alone and your child or the patient continues to have seizures, then you do need a surgical evaluation, because as we stated before, it could prolong the life of that person.
Yeah, don't stop at the MRI, keep digging.
That's right.
Yeah. All right, next slide, Audrey.
So
Kind
this
of
is
a
a
busy
very
slide, but let's go through this one by one.
Sure. This is a
Yeah.
great manuscript. I think I might be a middle author in there somewhere, but this is a magnetic resonance imaging guided stereotactic laser ablation therapy for the treatment of pediatric epilepsy, a retrospective multi-institutional study. This is an important study that involved many different institutions across North America. They all pooled their data together to say and address the question of how effective is laser ablation and what are the complication rates compared to open surgery. There were about 225 patients at 17 epilepsy centers. And they compared basically patients who had open surgery to patients who had laser ablation. And there were some exclusions, like patients who had corpus callosotomy, so those patients were excluded. And this represents all comers. So any patient who had epilepsy, which means that you have to take this with a grain of salt if you're trying to interpret the data with your child or patient in mind. But what it found was that the average anesthesia time was 6 hours. These are not super short surgeries, although the cutting and sewing is actually very short. It's the safety protocols and the creation of the three-dimensional space around the brain that really takes a lot of time. The cranial fixation varied between frame-based stereotaxy, robotic stereotaxy, and frameless stereotaxy. And stereotaxy is a big word, which means to touch a point in space. And it's a lot like the GPS system of the world can basically touch your cell phone in space and tell you where you are. That's exactly what we're doing in the OR when we talk about frame-based stereotaxy, frameless stereotaxy. We're creating a three-dimensional GPS system where we can target effectively the area of brain we want to destroy. We do place the electrodes or the lasers in this case using MRI. And then the results of this study showed that the majority of these patients were discharged 1 day later.
That's amazing.
50% were discharged 1 day later. The
Yeah.
majority were discharged 1 to 4 days later, 90%. And that the short-term complications were extremely small, 13%, compared with the open group, which was 30%.
Yeah.
So overall, very safe process with good, what we call perioperative outcomes.
These statistics on discharge are really amazing to me. We're a craniotomy family, and it takes 7-10 days before your child can go home. And it's a massive scar, staples and all that stuff. And it's necessary when it's necessary, but to be able to go home the next day is really quite something.
Yeah, absolutely. And the surgical process can be repeated in the future if it is, not as effective as you were hoping for, with similar results, home the next day.
That's great.
Next slide. So this is what you might see with lasers. On the left, you can see robotic frameless stereotaxy. You see the ROSA in C on the bottom. That's the cranial robot. And then there's a big circle. That's the O-arm. That's an imaging device that is basically a portable CT scanner that we use in the operating room. And that helps us understand and create stereotaxy, as well as confirm placement of lasers. In the top on A, you might see trajectories, which is a big word that means the direction of the laser. And so in this case, the arrows indicate, the direction that you're putting the laser in. So the one on the bottom is actually coming through the forehead, through, again, a 3 millimeter incision, a 3 millimeter bony hole, and going down the length of the corpus callosum. And the other two are coming from above into an area of the corpus callosum named the genu and the splenium. And then you can see the robot in action there in B, and it's hovering over a child's head, and you see several bolts, which might in a few minutes have a laser going through it. And then you can see what that looks like in B. It's a different bolt system in B. This is the proprietary bolt system for Visualase that has these wings on it, and it allows you to kind of screw it in. But you can see how, quote, invasive this is. It's a very tiny incision above the child's ear, and the bolt is in place, and that plastic tube, that is basically the 1.65 millimeter tube that conducts the laser through it. So much different than previous large incisions that mobilize the scalp and cause a lot of perioperative pain and increased infection rate and so on and so forth.
Yeah, really quite small.
Okay. So what's the goal? Well, the goal is always no seizures, no side effects. I mean, that's the best we can do. And in many cases, laser ablation is curative. How many cases? Well, when we look back at that previous manuscript, we saw that it was about 50% curative, compared with the open resection group, which was about 60% curative. So none of these are 100% curative. We're talking about a very complex condition, and we're talking about looking at all patients. So it's not like we're looking at a specific group of patients. So when you look at all patients and you compare the seizure freedom rate, the difference between laser ablation and open surgery is about 10%. Overall, you can expect 50 to 60% seizure freedom with both of those modalities. So it is important to note that palliation, or the reduction of seizures, not necessarily seizure freedom, but the reduction of seizures can also be quite meaningful. And that this is another secondary goal, is any control of seizures in a patient who has no control of seizures, given only medical regimen alone.
Really important to sit down with your doctor, with your surgeon, and talk about what the goal is and what the expectations are. And also important to understand that continuing with medication, you're at 0% chance.
That's right.
Yeah, 0% chance, which I really try to remind families, you know, you might not get 100%, but with medication, you might not get 100% with surgery, but with medicine, you're going to have 0% for the rest of the child's life.
That's right. That's important. It's important to remember that.
Next slide.
So laser ablation, is it effective? We talked about the cure rate. We talked about several different manuscripts that suggest that it's extremely effective. 93% improvements in seizures when you take all conditions together, at least 1 year later. And this varies now when you start to break it down by individual, what we call etiologies or causes for seizures. So for example, if you have cortical dysplasia, focal cortical dysplasia, malformation of cortical development, these are conditions that you're born with, and it causes a disruption of the normal formation of the cortex. The cortex is the gray matter on the outside of the brain. And I always tell patients who have focal cortical dysplasia that the human brain forms where the cell bodies, the neurons, are born inside and march out to the outside of the brain. And they all live kind of out here. And they form 6 perfect layers, like the biggest marching band in history. And if they don't form 6 perfect layers, then they're malformed. And those malformations tend to cause seizures. Now, often, in some cases, focal cortical dysplasia type 2B, for example, and other subtypes of focal cortical dysplasia type 2, they're identifiable on an MRI scan. But what we don't know is how diffuse they are. An MRI is not a microstructural image set, it's a macrostructural image set. So what we see is not necessarily the extent of abnormality. And so when we try to treat these patients with focal treatments like laser ablation, it doesn't necessarily work as well as a large resection might work. Now, if you're a 15-year-old person who plays basketball and you have seizures and you have a focal cortical dysplasia, maybe a very large resection would cause seizure freedom for you, but it also would be associated with significant deficits. So this is how we sort of decide how to approach a seizure onset zone, especially if it's something like focal cortical dysplasia.
So again, really important to have that conversation with the team about what your expectations are, what the side effects might be. And realistically, especially with cortical dysplasia, going in and understanding it is possible. Again, you can't predict 100% what the outcomes are going to be, but your child might be that 1 in 3 that doesn't have improvements. And you might have to start thinking about a bigger surgery, maybe on the second try.
Right. And also underscores the importance of coming in early. So the younger you are, the more we can do to your brain and you will recover significantly. The older you are, the less we can do without causing deficits.
It gets harder to do. All right.
So surgeons and epileptologists, I guess doctors in general, they make a diagnosis, they stage the disease, they treat based on stage, and they follow the outcomes. Very important is how are our patients doing? And that informs, in sort of a reverse feedback loop, what we do. So if we're doing something and patients do poorly, then we look at that and say, maybe it's not working. If we're doing something and patients do well, then we look at it and say more patients should fit into this category. There are 2 different outcome scales that we use to measure seizure outcomes: the Angle classification, which is simple, 1, 2, 3, 4, and then the International League Against Epilepsy outcome scale, which is a bit more complex. But basically, we're trying to understand, are patients totally free of seizures, seizure free? Do they have rare seizures? Do they have a worthwhile improvement, which is defined as more than 50% reduction in seizures? Or do they have no worthwhile improvement or even worsening of their seizure disorder? The ILAE scale is similar, but has more degradations based on the number of seizures that you might have.
Next slide.
Yeah, so the curative group of all conditions goal seizure freedom at 3 months. We're really talking about that 225 children group. We can see the 2 outcome scales: Angle outcome scale 1, 2, 3, which defines seizure freedom, rare seizures, worthwhile improvement, compared to the equal numbers on the ILAE scale: completely seizure free, only auras, no seizures, or 1 to 3 seizure days per year. Those numbers are essentially equivalent. There's 79% on the left and 80% on the right. Next slide.
Next slide. Yeah.
And so this is basically showing that again, but only comparing it to medical treatment alone in the middle, which again is 0%. And that might be somewhat controversial. Some purists might say, well, I mean, there are like 45 different anti-epileptic medications, and the odds are, that a patient might have 3%, but 3% is basically the max rate of seizure freedom in the medical group.
And I forgot to add a little body there on the left. So it should be the same number of kids on the left and the right. So about 1 out of 5 is going to not have a worthwhile outcome, but basically the same 4 out of 5 will have good outcome after laser ablation.
Right. So patients and families of patients often ask, is my child going to be the same child? What's the impact going to be? You're talking about destroying some of the brain. How is that going to affect them? And what has been known for a long time, and what continues to be true, is that seizures are bad for the brain, and that we very often get actually improvement in neuropsychological outcomes after we effectively treat seizures. And this is why I always tell patients and families that bad brain is worse than no brain, because of this neuropsych impact, and because this measures measures the effect of seizures on the brain over time. So in this group, in this cohort, which we've talked about before, 44 children had neuropsych testing before and after surgery. And when followed up at least 6 months after surgery, neuropsych outcomes were stable in 61% and actually improved in 36%, with only 1 child worsening in neuropsych outcomes. And so this, I think, really proves the fact that not only is there a survival benefit to laser ablation and actually to all cranial surgery for epilepsy, but that their neuropsychological outcomes, which is your cognitive ability, your ability to emotionally process things, all your spatial processing abilities, they all either stay the same or improve, which is really important to know.
Yeah, very important statistics there. Always a question people want to know, what's my child going to be like afterwards? It's the first question I had with my son, and it's tough to predict, but this data, these kinds of papers really all point to the direction that generally, almost always, the kids are very stable or improve.
That's right.
Next slide.
So this is a manuscript, MR guided laser ablation for the treatment of hypothalamic hamartomas. This is a retrospective study by Dan Curry and the group at Texas Children's. And so what we've been talking about is sort of all comers. When you take everybody who has medically refractory epilepsy and you treat them, these are the outcomes. But if you're interested in like how effective can laser ablation be, then you want to really distill it into a single cause of seizures. And hypothalamic hamartoma is the first type of epilepsy that anyone ever applied laser ablation to, and it was Dr. Curry who did it. And one of the reasons is the hypothalamus we talked about. It's very deep inside the brain. It's associated with all sorts of very critical basic functions of the human body. And a hamartoma is a non-cancerous lesion which causes seizures. And these seizures can be totally debilitating. They're associated with gelastic seizures, which are a laughing, what we call mirthless laughing. So no emotion associated with it, just total laughing. And they can evolve to become generalized tonic-clonic seizures or some sort of motor seizure. And they're very hard to get to because they're so deep inside the brain. And when people have previously tried to get to them, they can cause all sorts of problems like memory deficits, hypothalamic obesity syndrome, and these are pretty devastating. The seizure freedom rate was only about 50%, and the complication rate was also 50%. So very difficult to treat. Dr. Curry was the first person to introduce the laser into hypothalamic hamartoma. And when he looked at his very large series of 71 patients, this is a very uncommon condition, he showed at 1 year later, 93% seizure freedom. And sure, a couple, 23% of those patients had to have more than one ablation. But only one patient had significant memory deficits, and only one had something called diabetes insipidus, which is caused by dysfunction of the hypothalamus. So when you compare laser ablation for this particular entity to open resection or even endoscopic approaches for laser ablation, the seizure freedom rate is much, much higher, and the what we call morbidity or the deficits we cause by seizure are much, much lower.
Yeah, this has really been a game changer for that community of children, as I understand it. Basically, most have laser ablation at this point. Is that right?
I think it's actually now the gold standard for treating laser ablation, for treating hypothalamic hamartomas is laser ablation. That's correct.
That's terrific.
Just to briefly touch on corpus callosotomy, there are lots of ways to cut the connection that we talked about, those 300 million neurons and axons that attach the two cerebral hemispheres. One is open craniotomy. That's been done for 70 years now, and actually led to the winning of a Nobel Prize for split brain patients. It has been iterated on or improved by making a smaller incision. You can see in the endoscopic picture there in the middle, very small incision, through which a surgeon like my boss, Sandy Lamb, might introduce an endoscope and cut the corpus callosum. And they're associated with sort of lower risks of hydrocephalus using the endoscopic technique compared to the craniotomy technique with pretty equivalent seizure freedom rates. And then enter MRI-guided laser ablation. Of course, you saw this previously. You saw the little lasers in place. You can introduce these stereotactically. This is what we've been talking about the whole time. And you might choose 3 or 4 trajectories to adequately destroy the corpus callosum. So it does require more laser fibers than just destroying like one small discrete area. This is what we call a multi-fiber case, but also extremely effective. A lot of data from Matt Smith and his colleagues and others, and I have a published case series as well that shows that this is very effective. It's also cost effective, especially if patients have to stay in the hospital to manage hydrocephalus, and that the patient-reported outcomes are high.
That's great. So many options now available if the child needs corpus callosotomy.
That's right.
That's great. Okay. Just quickly for our families, there are 2 social media groups. These are for your information only. We don't endorse or guarantee the accuracy of any statements that are posted in these groups. They're not our groups, but there's Pediatric Epilepsy Surgery Support, where you can talk to other families about their experiences, and as well as corpus callosotomy families coming together. Next slide. In terms of what we offer for our families, here are just some of the things. If you're considering laser ablation or another type of epilepsy surgery, we have trained and certified parent support navigators. They've all received 6 months of training in what's called evidence-based peer support practices. So they know how to talk to you, they know what to say, and also, more really importantly, what not to say. They're not going to steer you in any one direction or another. They're just really going to, I'd like to say, hold your hand through the process. This can be really scary. Oh, can you go back, Audrey? We provide free school training for you after surgery if your child has any kind of the deficits, perhaps, or you just want the school team to understand. We'll train them for about 2 hours to understand the educational implications of surgery and of epilepsy. If you need help getting to a level 4 epilepsy center or to an experienced epilepsy surgery team for a surgical evaluation, we provide up to $1,000 in reimbursed travel funds. Please go to our YouTube channel. We have a lot of webinars on there. Everything from understanding when your child is drug resistant, all the way through surgical evaluations, the different types of surgeries, the IEP process. That's a lot of fun. Vision issues, transition to adulthood, all these other things that we all worry about. And then please mark your calendars. August 1st through 3rd is our biennial family conference. This is held every 2 years, where you will learn from some of the world's top experts in neurosurgery and anything neuro, as Dr. Raskin said earlier, and it's 3 days in Boston. We will go ahead and take some questions now, if anyone has them. I don't see any. I'm going to go ahead and turn off the recording so that people feel more comfortable with their questions.